Right, thank you very much. First of all, welcome. Thank you very much for coming. We're absolutely delighted to welcome Jeremy Hunt today, who has a huge job, very, very busy, so very kind of him to give his time to come and speak to us today. We're going to be hearing about his vision for a fully digital NHS and actually what that means for people, for patients and staff. And at the end of that, we're going to have some time for Q&A, so please do have a think about some clever questions you'd like to ask. Just before we kick off, just like to say, obviously the NHS has had a bit of a patchy past in terms of technology, bit of criticism. Yes, the fact is the NHS is probably, or definitely the biggest user of new technology in government. It consumes absolutely huge amounts. And this government appears to be incredibly keen to make a real virtue of that for people. Our research here in the Better Public Services Project shows that people are really up for more choice, more information, the use of technology to help them understand services better and access services and understand the quality. And we were really happy to host Tim Kelsey before this, just before Christmas, and he talked about his vision for opening up more information and giving that to patients so they can understand what kind of quality there is available in the NHS. So the real revolution now for this government appears to be not just looking at the back office and making things more efficient, but actually using technology to help people choose services. And I personally think that the closer we get to that kind of position where people can very easily look at the quality on offer in the NHS, and the NHS, by the way, is leading this whole field right across public services. My area of research is across public services. This is well in advance of most other departments. The closer we get to that position where people can look at what's on offer, access it very easily, understand the quality, then maybe we'll get closer to that vision that politicians since Tony Blair have been talking about, where we have people that can genuinely understand what is on offer and they're empowered to make genuine choices about the services that they use, and those are then in turn configured around their needs rather than the needs of the system. And it sounds certainly from what Jeremy has been saying already that this government's very keen to be progressing towards that, and today he's going to give a keynote speech, which is why we're especially grateful to him for coming to set out what sounds like a really bold vision. So please join me in welcoming Jeremy Hunt.
Well, thank you very much indeed, Sean, and good evening, ladies and gentlemen. In my 2.5 years as a cabinet minister, I've followed this debate about the role of the civil service, and there's probably been two moments where, in yes minister terms, my civil servants have thought in a Sir Humphrey-like way that what I'm about to say is brave. And one of them was one of my first speeches at DCMS. I think it was in May 2010, when I announced that by 2015 I wanted Britain to have the best superfast broadband in Europe. And that was a period, if you remember, where there were floods of complaints about the slow broadband speeds that people were facing. Still not a problem we've cracked. And I think today is perhaps the second of those brave moments, and both of them seem to be relating to technology. But I'm very delighted to be here, and I'm very grateful for the interest that Policy Exchange has shown in this area as well, because I think it is absolutely critical. In 1953, when the NHS was just 5 years old, two men named Smith took a flight from LA to New York, and they started chatting. One, Mr. Smith, was the head of American Airlines, and he was having a nightmare coping with the explosion in demand for airline travel. Back then, it could take 3 hours to book a single ticket, and they were dependent on the amount of work that 8 people huddling around a single Rolodex could manage, and they'd reached their limit. Mr. Smith was desperate. The other Mr. Smith worked for IBM. And that chance encounter transformed the industry. It led to a new computer system that allowed any travel agent anywhere in the country to know which seats were available on any flight, book and issue a ticket, all in a matter of minutes. And the implications were massive. Flying went mass market. American Airlines became one of the most successful airlines in the world. And we're still using the same system 60 years later, with the internet allowing us all to become our own travel agents. But think how history would have been different if the man from IBM had been sitting next to a Mr. Smith from the NHS. What they introduced to the airline industry 60 years ago, we still haven't done for health and social care today. The revolution that's transformed much of our daily lives has only just started to touch healthcare. And today I want to talk about why we need to embrace that revolution with enthusiasm, but also the pitfalls if we get it wrong. Right now, one of the biggest challenges facing the NHS is the Francis report about the appalling abuses of care at Stafford Hospital, shortly due to land on my desk. And I am clear that our response to that report must be about getting the culture and values right in the modern NHS, as much as about regulation and systems. Now, technology is not the answer to this. It can never replace human interaction, nor the care and compassion that must be at the heart of what the NHS stands for. But today I want to argue that it does have a role to play if we're to give doctors and nurses the time and space to deliver on those core NHS values. The clearest example of this is patient records. Because they're mainly paper-based, they can only be in one place at a time, only seen by one person at a time. So they're no use to a patient on holiday in Gloucester if his file is in a GP surgery in Godalming, or to an ambulance driver picking up a frail elderly woman in an emergency who, if he had her notes, could see she was a diabetic with a heart condition who had a fall last month. They're no use to a hospital doctor who might not be aware of a patient's other medication and prescribe drugs incorrectly, potentially lethally, because the notes have got lost. Unaware of a patient's full history, complications arise in surgery, diagnostic tests are repeated unnecessarily, and patients find themselves having to repeat their medical history over and over again, sometimes several days on the same day in the same hospital. Other countries are making great strides. In Denmark, people can see their hospital records online, and this year will be able to see their GP records as well. In America, military veterans who have their own healthcare system, not unlike the NHS, can download their own health records, something that almost 20,000 veterans do every month. In Sweden, over 85% of prescriptions are transferred from doctor to pharmacy online. And here in the UK too, we have some interesting pioneers. King's College Hospital, for example, is on track to become fully paperless by the end of the year. And the drive comes from clinicians who demand to have the right information in the right place at the right time. They've introduced electronic prescribing, and nurses use an iPod Touch to record and monitor a patient's vital signs at the bedside. Maudsley Hospital's My Health Box gives their patients online access to their hospital and GP records, a world first in mental health. They can also feed back on their care plan, helping them to take control of their own healthcare. And Newham Hospital is piloting using Skype for diabetic outpatient appointments that don't require an examination. Missed appointments are down by 11%, patients don't have to travel, and the quality of care is improved. But today I want to argue that we need to go much further, much faster. So I'm setting a new ambition for the NHS, which is that I want it to become paperless by 2018, the most modern digital health service in the world. Patients will be at the heart of this change, which means allowing for those unable or unwilling to engage in technology. But between the NHS and social care, there must be total commitment to ensuring that their interaction is paperless and that with a patient's consent, their full medical history can follow them around the system seamlessly. Now, this will be a profound change with huge impact, impossible to underestimate. And with profound change comes profound challenges. First, perhaps unsurprisingly, is money. If Labour fail to do this with their billions, how can we hope to do it on a much more limited budget? We shouldn't forget that local hospitals and local GP practices spend their own money on technology all the time. We just need a much more ambitious vision as to how to make that money and that investment count. Every NHS organisation, including all 266 NHS trusts, has a major incentive to do this because the savings are so enormous, 4.4 billion annually, according to today's PwC report. That money released to spend on better care can go a long way towards helping them deliver health services sustainably in a time of real financial pressure. Second, there is an objection that this shouldn't be a priority because we want nurses talking to patients, not looking at iPads. But how many times do we see a nurse station in a ward with nurses unable to catch your eye because their heads are buried in paperwork? Proper investment in technology means more contact time with patients, which is why the Prime Minister announced a £100 million fund to help nurses take advantage of it. Then there is the objection that patients don't want technology, and it is true that only 3% of people book GP appointments online, but 29% of people say they want to. Before online banking became available, were customers marching in the streets demanding that banks put their accounts online? Of course not. But that didn't stop people going online in droves, with 80% of us, including a third of pensioners, now banking online. So never let this be said to be something that is only of interest to younger generations. Then there is the critical issue of data security, which Fiona Caldecott is reviewing right now. Clearly, we need protocols so that people can be comfortable that their data is only being accessed when necessary and with their permission. But if the banks can make people confident that their money is safe, we must surely be able to develop a system that keeps medical records safe too. And there's the importance of the doctor-patient relationship. And there will be many times when only a face-to-face meeting will do. But allowing repeat prescriptions, for example, to be booked online will free up much more time for such meetings, as well as offering a better and more convenient service for patients. And finally, people say we've been here before, that Labour tried it and failed. Well, the truth is that Labour had the right idea, but the wrong approach. Labour's Connecting for Health became the NHS equivalent of ordering an aircraft carrier, a project that became over-centralised, over-specified, and ultimately impossible to deliver. What works, and you can see this everywhere, is local solutions, local decisions, and local leadership. Most systems won't necessarily need to be replaced, just updated or adapted so they can talk with each other. 1,000 different local solutions linking together using common standards. And if this sounds incredibly complex, it's actually very commonplace. It's why your BlackBerry can talk to my iPhone. It's why all of those apps on our phones integrate so seamlessly. It's why you can use any computer, phone, or tablet and log on to the internet to catch up on the latest news or watch a YouTube video. Things don't have to be the same, they just have to be compatible. Now, today's report by PwC confirms what we already know, that the right sort of technology, used in the right way, can release billions of pounds to be reinvested in better, safer care, and millions of hours of staff time for better patient care. And it can do something else too. Over 1 million people have some form of contact with the NHS every 36 hours. and have done so for over 60 years. This produces mind-boggling amounts of data that, if properly used with the right safeguards, can help improve treatments, unlock new cures, and transform the face of modern health and social care. The stakes are high, but already we have made real progress in preparing the NHS for a paperless digital future. In November, I announced in the NHS mandate that by March 2015, everyone who wants to will be able to get online access to their GP record, as well as book appointments with their GP and order repeat prescriptions online. E-consultations like those in Newham will become much more widely available. Today I can confirm that the NHS Commissioning Board have agreed that hospitals should be ready to share digital data from April 2014 and to adopt paperless referrals from April 2015. It's currently working on detailed guidance to help local NHS organisations make the leap. This follows on from other recent steps, changing the standard NHS contract to insist that providers comply with defined information standards, setting up care.data, a service to give local commissioners timely and accurate information on the performance of providers. From this summer, we'll begin to publish huge amounts of clinical data on a wide range of surgical procedures, everything from vascular surgery to bariatric surgery, bringing unprecedented transparency to great swathes of NHS performance. And to drive all of this, from 2013-14, the NHS number will become a patient's primary means of identification within the health and care system, enabling all of their records, wherever they are, to combine around the individual person. So, to conclude, technology is not a holy grail or a silver bullet for all the challenges facing the NHS. It must always be a means to an end and not an end in itself. But properly adopted, it has the potential to play a central role in facing up to the core challenge of dealing with an ageing society in which patients insist on a more personalised service. As Bill Gates said, never before in history has innovation offered promise of so much to so many in such a short time. Well, health needs to be at the front of the queue in taking advantage of that promise, and I'm determined it will be. Thank you very much.
I can see people, but thank you very much, Jeremy. I'm going to do some Q&A about, may I make a first point? It's really interesting to hear you talking about, you've seen examples in other countries of where they're really using technology, taking things forward, and just a little anecdote from my experience in government, and I can't remember which year it was. There was a flu outbreak, the last flu outbreak there was, either 2010 or 11, and there was this real crisis of people running out of flu jab supplies in their local areas, and nobody knew where to get jabbed from, and it was a big crisis. And afterwards, we had some people over from Spain. I can't remember which that they ever sort of devolved to some government, but they basically said, we saw that crisis happen. We had the same thing where we are. We set up for the equivalent of what was about £5,000. Just a little service. It was a number you could text. You text, I don't know, flu jab or something to this number, and it used either your GPS or your postcode, and it said, here are the practices around you by distance that have got flu jab supplies, and here's what place you are in the queue. So, technology is just unbelievably transformative in healthcare, and it's been you're right, it's been a long time kind of catching up, so it's really great to see such an ambition for it now. So, but anyway, I had prerogative to make the first point, but I'll take a question from you, if I may.
Okay, thanks, yeah.
Say who you are and where you're from.
Jeremy's former constituent, you know my interest. So Jeremy, the Conservative manifesto said, we'll give control over personal data back to individuals. Now surely, for the health record, for two very practical reasons, it's important to do that. One, there's no way you can manage the permissions across a complex bureaucracy like the NHS of a centralised or a centrally held health record. And the second thing is, only the individual can put their health record together with their exercise records from their fitness bike, their diet record, all the information they're getting back from the My Data policy, about lifestyle and so forth. Only the individual can make an integrated, holistic view of how to keep healthy. And surely that means individual control of the health record, not central control of the health record.
Yes, William, and by the way, nice to see you. Since you deserted my constituency. I think that's right. And I think there's sort of 2 points I would say within that. I think that I don't, as I say, I want to recognise the validity of Labour's ambition in what they were doing. But I think one of the things that was wrong about it was the idea of a central database, partly because of the risks in terms of security and the ability for it to be hacked into and all of that sort of thing. And I think one of the big points, if this is going to be successful, is that we have to give the public confidence in the security of this system. And I think that probably the home, although nowhere is ever really home if you're in the technology world, but the home for these records will probably reside in GP surgeries. I think that's sort of the heart of where the technology system will work, and that's where you'll give your permissions. But I think the heart of this probably will be, because that's the place through which most people access the NHS. And so what we want to do as a first step is to make sure that those records are liberated for people to have control of, but we'll be asking GPs to set up systems. And then the next step is to make sure that through that GP record, you can access anything that happened to you in secondary or tertiary services throughout the NHS. And so for the first time, GP in many places, it does happen in 1 or 2 places, but the first time in many places, GPs will then be able to see a full picture as to what actually happened to someone in a hospital visit. And then I think what we'll find is that that will be incredibly useful in hospitals, because consultants will then be able to see a full record of what's happened to someone prior to them arriving in a hospital. And then, of course, you've got the social care system. And for the frail elderly, one of the big shifts that needs to happen is the move to an integrated care model, where people are actually looked after proactively in a way that avoids the sort of the regular tipping over the edge where they end up being rushed to A&E, which is probably bad for their health, but is the only thing the system is able to do in an emergency. Whereas actually if they were proactively looked after differently, we could actually avoid them being tipped over the edge in that way. And one of the ways that you do that is by making sure that the health professionals who are responsible for those people actually have a full picture of that person. So there's various links in the chain, but I think the real point in this is that we do need to give people confidence that their medical records are secure. And that will most likely in the early days, particularly with frail elderly, be a conversation that they have with their GP. But I think I'm starting the debate today. The system has got time to work it out, and I'll see what responses people give.
Right, I'm going to take the lady at the back there.
Sean, Jeremy, thank you. I'd like to give a personal story. Yes, this morning I was woken up by the council saying, please move your car, on my text, on my phone, because I was parked in a place that was about to have tree cutting go ahead. And so I think that, and also I have somebody who does things with in a private capacity with the back, who I can book online with. And I broke my toe last year, and it took 5 weeks with the most amazing NHS support to get papers and photographs moved from one hospital to the other hospital. And I said, I don't need this much support. Please just tell me where to go and pick them up. I will move my photographs of my toe myself. They wouldn't let me. So I'd like to support what Jeremy is saying and say that if the council can tell me where to move my car, I would like to be able to move my medical records in the same easy way. So it's more of a statement of support than anything else.
All right. Nick Bosanquet, sorry for the microphone, I'm going back and forward, but...
Thank you very much, Minister. Nick Bosanquet from Imperial College. We want this to happen, the paperless economy, but we're going to have to be very realistic about the blocks to change, which include a lot of unwillingness to share information. I would suggest that we take a step-by-step approach. We focus on disease areas and get a shared motivation of patients, patient groups, clinicians, nursing staff, and carers to develop the system. Because unless we can show that it's not just producing a vast mass of information, it's really delivering results for patients who've got really serious problems, I don't think we're going to make the progress that you want to see. But there are an awful lot of factors blocking it. But from my experience with the cancer strategy and with the national framework for coronary heart disease, which in different ways have been huge successes, I would suggest more of a sort of disease focus in the first phase to show that it can really work in these disease areas.
Well, let me reflect on that. I think it's a very wise thought that we need to take these things in a step-by-step way. I think that our instincts were that if we were going to sort of prioritise, we would probably prioritise a certain type of person rather than disease, in particular the 3 million people who are likely to have 3 or more long-term conditions within the next few years, who are the people who are coming in and out of the system with great regularity. But I'll take that thought away and reflect on it. Thank you.
COPD is another area which is very possible.
Can I take the chap in the pink tie and then we'll go to the next door neighbour?
I'm Peter Barnes. I'm an investor in VitalPack technology, which captures vital signs electronically at a patient's bedside. So we're very much the foot soldiers in your revolution. My question is really around your localization issue, the localism issue, that what we find, we're now installed in 14 NHS hospitals. There's been a 20% reduction in patient mortality in the wards that we've put it on, and not a single outbreak of norovirus in any of those wards. So it should be a no-brainer for hospitals to be buying our technology or an equivalent. And yet, to sell it, we have to go hospital by hospital, and within each hospital, we have to convince separately the nursing director, the medical director, the IT director, the finance director, the chief executive, and the board. So my question is there any way in which there can be some central approval of technologies which the government recognises have achieved benefits for patients that can speed up the dissemination of good IT across the NHS?
Well, thank you for the work you're doing, and you've obviously been doing it for some time, and it sounds like it's having very spectacular results. Let me think about that. My nervousness about a central process. I mean, first of all, before I went into politics, I ran my own company, and we pitched for a number of public sector contracts, and we found it was an absolute nightmare. The only consolation was when you won one, it was a nightmare for all your competitors, and so the kind of, the barriers to entry are very high once you're inside, but that's part of the problem, really. And my nervousness about central processes is that actually you might increase the bureaucracy. What I'm trying to do at the moment by setting this date is to start a debate inside all the 266 NHS trusts. We've got 8,000 GP surgeries, and to give a sense of momentum and inevitability about a lot of things changing, and to get everyone to have their own discussions about what they're doing, and to try and get local ownership so that people start more actively looking. And I think there's a twin message, if you like. One of them is to managers of these organisations, and for them, I really hope they will salivate at the thought of the £4.4 billion that PwC are talking about. And I think a few years ago, people would have been hugely sceptical about that sort of figure. I think now people aren't. I think people really do. They know that retail banking has cut its costs by a third because of the move online, for example, and these are real figures. But my other audience are the people who work in the NHS and the NHS patients, for whom I want them to see this as an opportunity to save lives and improve the quality of care. And my hope is that therefore I can stir up interest in this from many different directions.
Great. And chat right next door.
Masood Waladi, I'm a co-founder of Circle. I'm delighted, as a doctor, I'm delighted actually after the setback that we had around electronic patient record, you starting it, but from different point of view of localism. The question I have, in Huntingdonshire, we want to have integrated care. We have GPs, we have community, we have hospital, and all the doctors and clinicians, we want to do it. I want to ask how far we can be disruptive. Because when I went to South India, they did electronic patient record with a smart card chip for 8 million population at $3 million. And the question I asked, Kaiser did it at $1 billion. When I saw them 10 years later, they said with the new technology, really can be disruptive. But it requires a lot of localism, and a lot of things has to be taken out of the system and liberating localism. So I'm delighted you say it will be local, and I just want to know how far you're happy to let us be disruptive.
Well, my short period in health politics has taught me that disruption that comes from the centre is usually highly unpopular. But disruption that is local has a much better chance of success, and particularly if it has clinical engagement, it's led by local clinicians. And so I think the answer to that is providing, I expect this to be disruptive in a positive way, but I don't want to be someone who's sitting at the centre planning grand strategies. I think it's something that will work best if there's real local ownership. And where you can help me, and where the GP surgeries that are on board with this, the NHS trusts, the new clinical commissioning groups can help me, is where there are barriers locally towards change happening, where we can help from the centre remove some of those barriers, then I think you should let me know, because I think 70% of my work has to be about removing the barriers to making this change happen. And I think sometimes procurement processes are one of the examples actually where that's the case, but I'm sure there are many others.
Okay, can we go to Simon at the back there?
Simon Hill from Cerner. Jeremy, absolutely love everything that you've said. Would endorse it all 100%. For those of you who don't know, Cerner is the largest health information company in the world. And we do this up and around the world and have been doing it for 30 years. The thing I would say is that whilst we support everything you absolutely said, the other thing to say is that what you're proposing is incredibly difficult to do. And anyone who looks at Connecting for Health can see that. The two things I would say is that to do it and to be successful, and we know this from seeing organisations around the world doing it, two things need to happen. The first is that it needs to be clinically led, and the second is that it needs to be done as part of a change management agenda within healthcare. If you do those two things, success has a much higher chance than if you don't. So more of an observation and a plea than anything else.
Okay. Should we move on?
I note the point, Simon. I agree with you about the clinically led. I'm sure you're right about change management process. I'm not sure I really know what the hell that is, but it sounds pretty impressive.
We're going to go to Mike Birtwistle, and then we'll come to Chaka.
Yeah, Jeremy, Mike Birtwistle from NHP Health Monday. Just really actually following on slightly from Simon's point. I mean, it's a very, very easy thing to talk about clinical leadership in this, and yet actually to get clinicians engaged in technology with all the pressures on them is a difficult process. I mean, I think there are some good examples in terms of information. If you look at, say, the National Cancer Intelligence Network, I think that's a really good example about how you can get clinicians to lead. But how are you going to do that at scale? Because, I mean, your speech was great and it had lots of inspiring examples, but unfortunately, the inspiring examples we tend to be about, we can count them on two hands. And I think the danger is, next time we have a speech, it should be about 4 hours long because of all the great examples. But how do we get there? So how do we turn good things which happen occasionally into the run-of-the-mill things which happen all the time?
Well, that is actually the very first time I've ever been asked for my next speech to be 4 hours long. So I'm deeply flattered that you think I could hold your attention. But look, I mean, the point is a very well-made one. My experience, and this has actually been one of the surprises for me since becoming Health Secretary, I think this morning I met my first technophobe in my whole time in the NHS. Every clinician I've spoken to has been unbelievably enthusiastic about this agenda. And, you know, hospital managers are enthusiastic, perhaps you would expect that, but the people running clinical commissioning groups are enthusiastic. And it wasn't until I did an interview on Daybreak with Dr. Hillary where, for the first time actually, someone made this argument that, you know, computers can't admit people to hospital, computers can't hold people's hands. And I was quite shocked that people are still making that argument, because I've been so surprised at how positive people are in the NHS about this. So I think, I don't think, as far as clinical enthusiasm is concerned, we're going to have a big problem. But I think what we need to do is to understand where clinicians are coming from. So, for example, when it comes to GPs, I think they are feeling very pressured and that there is a big shortage of time. So one of the things in this PwC report, what it talks about is a number of hours freed up for GPs, and that's something we want to do more work on. Inside hospitals, because the savings that you make from all these technology investments are going to remain with the institutions that make the investment. So I think once people understand that this isn't savings that are going to be snatched away by evil ministers, this is something that's in your interest to do, I think even clinicians might start to think, well, actually, this is going to be in our interest to engage with this. And so I think I don't want to underestimate the process, but I think that there has been a change. Perhaps the iPad has a lot for us to thank it for, because I think, you know, so many people have iPads now, and that's just changed people's daily lives in such a big way that you know, hospital consultants and lots of other people who might have been sceptical, I think, are in a very different place.
Paul Saper, LCS International, more importantly to Conservative Health, and colleagues today. Probably the most immediate thought that comes to mind is the PwC typically have been very conservative with their £4.5 billion potential savings, because there are clearly other areas out there where there's a lot to go for. I give you three type of examples for our speech next time. It could be something like orthodontics, where traditionally everything's been done in molds and you go up and back and you have to wait 2 weeks for the next meeting. That can now be done by digitalisation at a fraction of the cost, and it totally changed the economics. We look at the way district nursing is. We've got private companies coming in now, and they will get a lot more private productivity out of the nurses and how many patients they can look after in a day, in a week, or whatever it is. And thirdly, we had a Carter review. We had 2 Carter reviews. I'm looking at lab work and everything. And we at the moment, our lab costs, the Germans can do it and have a tariff rate of only 40p in the pound compared with what it costs every year. And in fact, they're just about to actually cut the tariff again by another 16%, because the lab companies are making so much money at a fraction of the cost compared with over here. And you realise just how much technology, digitalisation, new ways of doing things, the private sector can actually do. And there may even therefore be a lot of different means, like choose the book, that can be used in the system to actually quicken the whole process of change and the use of digitalisation in the system. So I'm asking the real question is, do you think competition can have a significant role here?
Well, I think you know, competition, of course, has a very important role. I mean, it's a means to an end. It's really about maximising the innovation that we have in the system. And I think the broader point is that you know, in terms of the scale of the savings, this may well be a conservative estimate. But I think there is a driver in the system now that didn't exist before, which is that for 30 years, the NHS had real terms increases of around 4% a year, at the same time as which demand was going up by 4% a year. Since 2010, because of the financial crisis, real terms increase in expenditure going up by 0.1% a year, but demand is still going up by 4% a year. So if you do the maths, everyone throughout the NHS is having to make 4% productivity savings every year in order to cope with the increasing demand for their services. Now, the NHS hasn't had that before, and I think that is encouraging people to ask a lot of questions about how to deliver services more efficiently. And the NHS has been doing that for the last 2 years. It's been doing it very well, but it's been doing it, it's had to be some very difficult decisions. You know, there's been pay freezes, and there's been a certain amount of low-hanging fruit. I think we now need to look at technology and look at it in a very ambitious way, because actually not only can it help us meet those productivity targets, but it can also massively improve the patient experience.
I'm just going to, just before that, do you mind if I butt in? Because I really want to make this point, which is my prerogative, because I'm chairing. But this debate, like you see this, I've seen this for years. I've been public service stuff for policy for years, and it's happening in every other public service. And it's basically, do we let 1,000 flowers bloom, as you described the India example, and you described different examples, or does government need to lead it, as Mike said, there are 2 great examples, does government need to give it a push? And actually, what I've seen from the research here across the world and what this government is doing is definitely you want to get to a place where 1,000 flowers are blooming, you want to just remove barriers, as you described, and create competition. But sometimes government has just got to put in a little bit of a framework to start with some people that you described, perhaps people with certain conditions, just to show that what is possible. And then all these providers will get a bit more confident about the market, and you can kind of really kickstart it. Sorry, my little tuppence worth. But the chapter's here in the front, please.
Thank you, John Seddon from Vanguard. You may be aware, Minister, that a similar initiative in America has been reported on today. We're supposed to save $81 billion, much more ambitious, I suppose, with similar arguments to the PwC arguments produced by the Rand Corporation historically a few years ago now. I think you should have a look at that. I'm not a technophobe, but I'm concerned about whether you're solving a more important problem. Over the last year, we've been studying the English health system. In broad terms, about 2/3 to 3/4 of the demand in the system is what I would call help me demand as opposed to fix me demand. And the system doesn't respond very well to help me demand. Essentially what happens to people who need help is they get visited by quite a number of different specialists who look at them through their own lens. Ultimately, something might get provided or commissioned, but it doesn't meet the need in the context for that person, and so they represent. Whenever they represent, they're treated as though we don't know who they are, and they go through much the same sort of process again, meeting a multitude of people, multitude of assessments and so on. Now, the interesting thing about, the most important thing about this from a productivity point of view, is this is amplified sometimes 9 times, 12 times, can even be 25 times, consuming all of that resource, which I think is what's behind the RAND problem, the PwC problem, but that's another matter. And surely the more important problem to solve is how do we design a system that when people say I need help, we understand quickly what that means and provide that help, because that would be massively cheaper than what we're actually doing at the moment.
Well,
getting computer systems for them to talk to each other is kind of missing the point.
Sorry, I agree with everything you said until that last point. Because I think you put your finger on a very, very important change that needs to happen inside the NHS. I think the NHS is the best system in the world at dealing with discrete, curable illness. So if you need a knee replaced or a new hip, the NHS does it more cheaply, more efficiently and more quickly and more socially equitably than pretty much any country in the world, and I think it's really impressive how it does that. But the model of illness is changing a lot, and particularly with an ageing population, we're having a massive growth in people who have long-term conditions, which is perhaps a nice way of saying an incurable condition, that they're unlikely, but that can be managed and made a lot easier to live with, but is not going to go away. And there's a big growth. I mentioned the 3 million people, I think by 2016, who will have 3 or more long-term conditions. And most of these people are over 75. and they are going to be a very, very significant part of the burden on the NHS. And it's for those people that I think proper electronic records can make a massive difference in the quality of care they receive, because they're going in and out of the system the whole time. And if they actually were able to interact with people who could see the full picture of what was happening to them, I think not only would it make their experience better, it would make multidisciplinary working much easier, and professionals would be able to engage without necessarily being present. And I think we would be able to make this transformation that we really need, which is a big part of the ambition behind the new reforms, to create that local autonomy, to allow the local clinically led commissioning groups to put in place systems which allow integrated care plans, which is the real holy grail behind what needs to happen. So I think technology is going to really help that happen, but I do want to stress that I think technology needs to be a means to an end, and that is one of the critical ends. It's not the end in itself. And I have to say, I've identified 4 ambitions, or 4 priority areas, and I wanted all of them to be about something that patients would readily identify with, so improving the way we tackle dementia, improving the quality of care in the system, which are a couple of them. Technology was the exception, because you could argue it's about process, but I just decided it was such an important leap that the NHS needed to make that championing technology would be likely to help so many other things that it was worth doing.
Great. Lady with blonde hair here.
I'll stand up. So evening. I'm Nikki Flanders. I've just been appointed the Managing Director of O2 Health. For the last year, I've been heading the 4G strategy at O2 in terms of how we can unlock the possibilities of 4G. And I'd just like to share a quick observation and a suggestion, if I may. So during my last 2 months of being Managing Director of O2 Health, I've been seeing the clinicians that we've been working with, and we've been developing, co-developing with clinicians what they tell me are some fantastic tools for long-term conditions and various other efficiency tools. And the last 6 weeks I have made a point of going around to people in your team, people in the health sector generally, and the overriding observation I've had is, wow, this is great. We can see what the possibilities are. And it comes back to the gentleman's point there, so I don't know your name, but I think there are some very simple, from an outsider looking in of the health sector, very simple suggestions that we could work together on, collaboratively on, in terms of this change agenda. So this is about how we can disseminate what are the outcomes that these technologies are actually providing on a real-time basis. So what we're doing is we're looking at the outcomes and we're adjusting the technology. And I think if there's a way of disseminating that much more broadly and more rapidly, then the ambition that you laid out at the beginning of the session is far more achievable than the timescales. But it is about that change agenda in terms of people understanding how it can benefit them and how it benefits the patient, and seeing it for real.
Yes, I'm sure that's right. We need to disseminate best practice, and that's partly why I'm sort of giving speeches like this, because I want to try and enthuse as many of the 1.7 million people who work in the NHS ecosystem with the whole agenda. I'm a little bit reluctant to set up central structures to do that, because I think they can become very bureaucratic, and I think there's enthusiasm for this. I think the best thing that I can do at the centre is to make sure there is transparency on patient outcomes, so that people can see which parts of the country are doing best, which hospitals, which consultant teams are doing best in cancer survival rates, and then the ones that are doing best. I mean, I think the NHS is actually, a model of the importance of peer pressure. Doctors are very, very interested in how well they're doing against their peers, and so if we can unlock the information about where the best outcomes are, I think that creates a lot of momentum and interest. When it comes to O2 and mobile technology, I think one thing I'm particularly interested in is how you can help us offer better solutions for people with long-term conditions.
Yeah.
Because I think actually one of the key things for people with long-term conditions is helping them live happily and healthily at home for longer.
Yes.
And proper telecommunication support can be one of the things that can provide the reassurance that might mean, you know, that if someone has dementia, for example, they might be able to stay at home for longer, supported by a partner than might otherwise be the case. And I think the challenge I would give to you, if I might, is whether you're doing enough to make your technology simple enough for someone, for example, with dementia to use.
Yeah.
And I think that is a really big challenge because, you know, it's really pressing one yellow button and then immediately being in a video conference with a nurse that appears on your TV, so that for you, you know, the only thing that's new is there's a yellow button you can press and then you can be talking to a nurse in a minute. That's the sort of thing which I think, you know, is on the horizon.
What would be great?
You're going to tell me you can do it, I'm sure.
We have over 500 people that are currently patients, as well as the clinicians, that are co-developing this technology. We've got live, and it's actually helping people's lives as we speak. And that includes dementia patients. So it'd be great to show you how simple it is. So what we've done is that we have taken feedback from the patients, and they have said things like, we want the screens bigger, we want this in yellow, we don't want this in yellow, we want it in red. They're down to that level of detail in terms of the user experience to make it really simple. So I agree with your point, and we are doing it. And
Great.
and you know what we're getting back is we wish we knew about this. So it's not. This isn't.
Well, I haven't bought my checkbook today.
No. This is more about how we can, disseminate possibilities with all technology.
Okay, message heard loud and clear. You heard
Should I do a couple more?
Two more. Okay, let's go for lady with the green jumper on here.
Louise Marston from Nesta. Really pleased to hear this announcement, and also particularly the reference to research and the importance of data for learning and improvement. I wonder, picking up on Nick's point earlier about starting with a particular disease area, whether you've looked at the experience in Scotland, their progress with electronic records, in particular gathering data on diseases like diabetes, where they've got a national diabetes register, and whether you're looking at those as examples of how to do things or perhaps not to do things.
Well, I think it's interesting. I mean, I think overall the NHS in England does a lot better than the NHS in Scotland, but there are some interesting examples where Scotland does better, and one of them is dementia diagnosis rates. I didn't know about the diabetes example, but I will follow that up. One of the things that they've done in Scotland, I'm not sure the technology angle on this, but is they've proactively gone out into care homes much more to try and establish where more of the frail elderly are that they need to be targeting in their healthcare programs. But yes, I'm sure there are things we can learn from many different places.
Okay, I'm going to take the last one, which is this chap here with his arm up with another green jumper on, I think it is.
David Mortimer from Age UK. I think from our experience, we spend a lot of our efforts trying to support older people to gain the benefits of technology. One of the things we hear from them is that they're very enthusiastic about learning more about how to manage their health, but they don't necessarily have the skills or feel confident enough to do it. Part of a vision like this about making it paperless does have to involve those frail elderly that you've referred to many times, and in terms of their ability to self-manage the process, I would wonder how much resource could be put into supporting older people and others into being able to realise the benefits of what your vision is.
Well, I think the answer is we're putting in quite a lot of resource. I mean, we have a plan to have 3 million people on telehealth, which is making very good progress, and we think that we will fairly soon be the second biggest telehealth market in the world after the United States. And a lot of that is with older people, and a lot of it is about helping people to manage their condition. But I fully take on board the challenge that you're giving. The only thing I would say is that I think we also need to we need to understand that the benefits are absolutely huge for people who really aren't able to engage with technology as well. And even if you've never been near an iPad, if your ambulance driver is able to access your medical history on the way to picking you up, that will be massively beneficial to you. And so we need to recognise the benefits are for everyone, regardless of which stage they are in engaging with technology.
Great, well thank you. I'm really sorry that I know there are tons more hands up, but we have only a finite time, I'm afraid. Seems to me that the debate is certainly massive enthusiasm for the technology agenda. It's really patient-focused. Bit of debate here I detect on whether, on how much government allows complete innovation versus how much you kind of drive through a couple of programs to actually seed it. So really interesting to see how it pans up. But thank you all for coming tonight. A great set out of a vision that Jeremy wants to achieve, and some really great questions as well. Let's please show our appreciation to Jeremy for spending time.